Thank you. Good morning, everyone. Delighted to be here today. My name is Chris Marty. I'm a clinical lead musculoskeletal physiotherapist with Aneurin Bevan Health Board in South Wales. I'm also here in my capacity as the chair of the Board of Trustees for the Arthritis and Musculoskeletal Alliance. This panel discussion today will be interactive. We're going to be using Mentimeter in a few moments. There's going to be opportunity for questions embedded into this. And I'm really delighted to be with the panel here. We've got Sue Brown, the CEO of ARMA. We've also got Jane Taylor, who's had 40 years of lived experience with rheumatoid arthritis, also experience as a carer, and is on various trustee boards also, as well as ARMA, of course. And we have Dr. Anthony Gilbert, a research physiotherapist too. So I really want to move forward from Dr. Aoife Molloy's talk there. And what really resonated with me was that moral obligation to act on health inequalities and that economic obligation. And so what we're going to talk through today is how we can take action on tackling musculoskeletal health inequalities and deprivation, specifically looking at the ARMA inquiry. So who are ARMA? Hopefully a lot of you already know this in the room, but ARMA, the uniqueness of ARMA is this membership organisation. So it's a registered charity with members of over 40 in number, and you can see several of them there, such as Versus Arthritis, the Royal Osteoporosis Society, and indeed the Chartered Society of Physiotherapy. And its diverse membership offers both the patient and then professional voice to the musculoskeletal community. Now, in 2023, ARMA carried out a real ambitious inquiry, the first of its kind across the UK, into the first ever national inquiry around musculoskeletal health inequalities and deprivation. The aim was to highlight the issues, of which Dr. Molloy clearly made the case for the prevalence of those, but also to take action, to make some recommendations for us around the room. And it was interesting to hear some of the comments others made around physical activity before. And there is a lot that we can do as physiotherapists in this room. And so hopefully you're going to be able to take some of those away. The few most significant findings were around social and economic factors that influence poor musculoskeletal health. And these are around poverty, education, employment, and environment and food culture, which impacts then or deters physical activity and a healthy diet. Like we were mentioning before, these health inequalities are preventable and avoidable, not just unfair. So why focus on this? We know that people with musculoskeletal conditions living in poverty have less ability to address these modifiable risk factors. People in deprived areas also develop musculoskeletal conditions earlier than those in the less deprived areas. And I think crucially, and what anecdotally us as physiotherapists will know, is that people in these deprived areas are more likely to have multi-comorbidities. And actually this, therefore, means that they are more clinically complex. So we're going to set out today the case for change and the case for action using the findings from the ARMA inquiry. So I'm delighted to hand over to the CEO of ARMA, Sue Brown, to go into this further.
Thank you, Chris, and thank you all for joining us here today. I'm going to outline the findings of the inquiry that ARMA carried out. First of all, I want to start by thanking our supporters. Without their financial support, we would not have been able to do this project. So we had sponsorship from Grunenthal, and we had charitable grants from Pfizer, Novartis, and Janssen. And Aoife's covered a bit of this, so I won't dwell on this, but just remembering health inequalities are systematic and avoidable differences in health between different social groups. But it's important to understand health equity. Health equity means prioritising care and treatment based on need. So understanding that some people are going to need more support or a different kind of support for the same condition. And it isn't really possible to tackle health inequalities unless you look at health equity. So obviously, ARMA is focused on musculoskeletal conditions, although I would say a lot of the findings and the process that we recommend in this report is applicable to other conditions. But if we just look at the information about musculoskeletal, you can see that there are differences between the most and the least deprived areas in the incidence of long-term MSK conditions. So the least deprived in England, Scotland and Wales, roughly 12 to 14%, and the most deprived, 20% to 26%. So a big gap. In Scotland, it's double. And all of that difference is preventable. There isn't some sort of genetic difference between the people living in the most and least deprived areas that predisposes them to MSK conditions. It's all preventable. And you'll notice there's no figures for Northern Ireland here. We have just launched our report in Northern Ireland, but unfortunately the state of health data in Northern Ireland means I can't present you with similar findings for Northern Ireland. So we wanted to look at the evidence for these inequalities related to deprivation and explore the possible underlying reasons. But most importantly, we did not want the inquiry just to say, look, it's a big problem. We wanted to propose actions that people can take to address those in the design and delivery of services. And we wanted to raise the profile of those issues and possible solutions so that people can actually take action. And I'm pleased to say that lots and lots of people who have seen our report are now telling us what they're planning to do as a result of having read it. Just very quickly, we gathered evidence, literature review, calls for evidence, lived experience survey. We did 4 evidence sessions, and Aoife, in fact, kindly took part in one of those. We synthesised all that information to develop recommendations, and we produced a final report which was published earlier this year, and you'll find that and a summary on our website. So first of all, it's important to understand the drivers of poor MSK health, those underlying drivers. And we picked out a few that we think are particularly pertinent for MSK. So first of all, it's important to understand only 20% of our health is driven by healthcare. The rest is around social determinants. But that 20% is also important, which I will come on to. This doesn't mean there's nothing you can do. But it is important to understand the context within which people are living. So poverty. Poverty is second only to age as a driver of ill health. And at the moment, 1 in 5 people in the UK are living in poverty. So this is not a small issue. Poor or lack of employment is also important. So we know that good work is good for your health, but poor work is not. And then education. Education impacts on things like health literacy, but it also impacts on those other 2. So your ability to get a good job, a stable job. So there's a sort of interrelationship between all of those top 3. And we then looked at modifiable risk factors. Note, I am not using the word lifestyle factors. This is not about lifestyle choices. And we chose physical activity and healthy weight and diet as the 2 that we think are the most important in musculoskeletal health. And there are big differences in these between the most and the least deprived areas. So if you live in a more deprived area, you are less likely to be physically active. In every area, activity levels dipped before the pandemic. In the least deprived areas, they are now back up to the level they were before. In the most deprived areas, they are not. And we know that one of the things that makes people more likely to be more physically active is feeling of safety. And you can see why living in a more deprived area, where maybe there are not green spaces or the green spaces don't feel safe, it makes it less likely for people to be physically active. And then healthy weight and diet. Huge differences in the levels of obesity between the most and the least deprived areas. So Again, it's important to understand the context within which people live. I heard a ambassador of the Food Foundation, a youth ambassador of the Food Foundation the other day, talking about the extent to which he is exposed to advertising for fast food from the moment he wakes up on his phone, on social media, on the bus on the way to work. And he said, fast food is the cultural wallpaper of my life. So this is not about willpower. This is about an environment, a food culture that deter physical activity and makes it very difficult to follow a healthy diet. So how can healthcare services address these inequalities? And we came up with a number of things. So first of all, knowing your community better, understanding the context within which the community you are there to serve are actually living. Developing shared ownership of services through engagement and co-production. Using data to identify, tackle, and monitor the barriers to access and unequal outcomes. And most importantly, avoiding inertia. It's terrifying, it's huge. We only control 20% of it. What can we do? What you can do is start now in a spirit of service improvement and try something, and then keep learning. Some of the other key messages that came out of this: paediatric services have particular challenges because the incidence of MSK conditions is lower. They tend to be covering large catchment areas. Parents in insecure work find it very difficult to take a day off work to take a child to an appointment. I cannot overemphasize the importance of supported self-management. Not, here's a sheet of exercises, go away and do it yourself. Supported self-management means a health coaching approach, peer support, social prescribing. And we did an oral evidence session on supported self-management. I would recommend it to anyone who wants to really understand what that looks like. Recognising the impact of living with multiple conditions. The people in more deprived areas don't just get more MSK conditions younger, same for other conditions. So they are more likely to have other conditions that are impacting, they all impact on each other. People's conditions don't sit in silos. Unfortunately, NHS services tend to. And then finally, the importance of that quality clinical encounter. So that trust between healthcare professional and patient, which has often been broken by the time you speak to someone, and having a coaching approach. So that process we then sum up in this image. The first thing is understanding the drivers of poor MSK health. That's the context that people are living in. Understand that. Secondly, act now. Do something because you can make a difference. Then it's about identifying that target group, and that core 20+5 is a good summary of the group we're talking about. Find out who is the group in your area, and it will be different for different places, that are struggling to access your services. Co-produce and deliver flexible services embedded in the community. And then finally, this thing about ensuring that you've got good supported self-management and a good clinical approach. But the most important message is this one, which is commit to act on inequalities and act now. It is challenging. It is a very complex environment, but you can make a difference. And I have emphasised the importance of co-production. That was important to us as we were delivering the inquiry. So I'd now like to hand over to Jane, who was one of our lived experience experts on our lived experience panel advising the inquiry. Thank you.
Thanks, Sue. So I'm going to just flesh out a little bit about the importance of lived experience and talk a little bit about some of the things that would help me as a patient and as a carer. And I have to say, education I would really, really advocate for, because I'm someone who's made it from a socially deprived background. Many of my relatives, 2 of my siblings, are still living in those conditions, one of whom I share care for. So I've kind of got out of that background, but I'm still very much part of it. I'm still very much involved in those communities. And I've also spent 20 years involved in co-production in MSK and mental health research and services. Only got a few minutes, so a slide is better than me talking at you. What's the importance of lived experience? Well, the main experience is that you actually find out what matters to the patient. And if only someone had asked that poor horse, you know, that their appearance was actually quite important to them. Because what I've found over the years, and what many people who are living with long-term conditions, particularly in poverty, find, is that the outcomes that matter to health professionals don't always matter to the patient. And if you don't actually find out what matters to the patient, then you're never going to improve and have effective services. You're never going to get people out of their conditions. You're never going to address some of the things that Aoife and Sue and you've already talked about in your questions. So that was the importance of having lived experience integral to the ARMA report. And the other thing about lived experience is that it tends to also help you understand, help researchers, help physios understand the drivers of poor MSK health, why people don't do things, why, you know, when you've got your exercises and lots of great helpful people like you telling you what to do, people still don't do it. Why don't they change their behavior? And we can kind of help with some of those things and work together to make effective services. So I'm just going to quickly go over a couple of things that we thought were very important and that certainly I, in my experience as a patient and carer, have certainly found would make a big difference to me. So co-producing things with your target community, really, really important. That is going to be the thing that makes everything most effective. It's the thing that you need to invest in. You need to invest in the community that you're not able to reach at the moment. Accessibility is a very big buzzword. And as physios, you'll all be very aware, I'm sure, far more aware than I am, of the need for physical accessibility. Physical accessibility is obviously very important, which is why we need to have much more emphasis on community services, of actually going to where the people are. But it's not the only form of accessibility. So if we look at some of the other forms of accessibility, economic accessibility. You know, I am now in a semi-professional job part-time, but I don't drive. It takes me maybe half a day to get to the 2 hospitals that I'm under. I need to take 2 trams or buses. It costs. For many people, they have to make a decision that they can't go. They can go once, they can't go a second time. They've got to choose what they do with their money. So it's important to go to the people and not expect the people to come to you. Digital, I'm going to just say briefly something about digital. And I know there's what looks like an interesting session on that coming up. But you know, we've almost become digital by default, and digital can be really helpful, but most people living in poverty don't have access to digital facilities. There was a report published last year that showed that almost 19 million people are living in digital poverty. They either don't have access to the kind of smartphones or computers, or they don't have the skills to use them. In my work, I work sometimes with prisoners in education, and I spoke to one the other night who has just served a 7-year sentence, but he's managing to do a degree. He's almost at the end of that degree, but in those 7 years in prison, he couldn't have access to a computer. And just think about that. You know, he's done a degree without access to a computer. He's on his final module. I'm helping him, but he doesn't know how to get onto, you know, an online teaching session, because in 7 years things have changed. So we have to think about going where the person is rather than expecting them, to fit in with you. So physical, economic, digital. Linguistic, we're much better now at recognizing people whose first language isn't English, but we're still not very good at recognizing people's level of health literacy. Many people don't know what physiotherapists do. They certainly have no idea what podiatrists do. And if you talk to people about occupational therapy, they tend to think it's going to be about getting them into work. So, think about the language, think about the assumptions you're making about your knowledge. We all do it in our own field. We assume everyone knows. They don't. The most important accessibility, though, I would say, is psychological. Aoife talked earlier about stigma, didn't she, and microaggressions. If it feels difficult for you to go to a physio session, you're not going to go. You might go once, you're not going to go back. People know that they're obese. They know that they smoke too much. They know that they're not eating the right food. They don't need to be constantly reminded of it. So make every interaction as pleasant as possible. My brother uses a lot of, not quite food banks, but certainly community cafes he has very complex needs. He goes to cafes, and when I talk to him and his community, his tribe, as I call them, about why they choose this particular place, because now they have to pay a very small amount, but they have to pay for the meal. And they'll say things like, because we get second helpings. And one of them said, because there's a tablecloth on the tables, and sometimes there's even flowers. And that makes a difference to people. Treating people with respect, making the encounters pleasant, make them social. It's much easier to go to something and keep going to something if there are other people like you in the room. And most people go back a second time, not because they want the physio, but because they want to talk to somebody that they met there, because they had tea and biscuits afterwards and got to know someone. So think about those kind of psychological factors. Make it flexible. I am a terrible candidate for physio, and there are only 2 physio initiatives that I've stuck with. And the reason I've stuck with them is because they were both made flexible in 40 years. I didn't have to fit into a 6-week pattern. I couldn't do that. They said, come when you can come. And if you can't come, don't worry if you can't get to a phone. Don't worry if something's happened with your child, and so on. And I kept going because I could drop out and I could go back in. And that's really important. Giving people, say, 6 weeks of physio, if something's happening in their lives, that's not going to work. Make it flexible. Allow people to drop in and out. Don't blame them for it. Co-production helps all those things. So that is, I would say, the most important thing. But also, be aware of the impact of social deprivation. We hear those statistics, but really think about them. We think about pain, for example. We know that if you are living in a socially deprived area, community, you're poor, you're twice as likely to suffer from chronic pain. If you're a woman in those communities, you're even more likely to suffer from chronic pain. If you're a black woman in those communities, you've got a worse statistic. So think also about intersectionality. People are poor, but poverty is experienced differently depending on your gender, your ethnicity. It's not just, a one-size-fits-all. So think about all those things. Thank you very much.
Thank you, Jane, and incredibly powerful and insightful for all of us. So hopefully there's a lot that you will have taken away just from the first 2 talks of this panel discussion, because it's now over to you. We've got Mentimeter. I'm sure a lot of you have used this before or other platforms. This is an opportunity for you to have your say about what you've heard. As we mentioned, we do have a networking session later in this morning, but this is an opportunity to say a little bit about what you feel and what you've heard this morning straight away here. There's also an opportunity in a moment to ask some questions in this section as well. So I'll just leave that up there just for a moment. And as you are all getting online there, can then skip to the next question. Hopefully you've all got that. Okay. So the question in this part, just one question, and then we've got a question later on, is what words come to mind when you think about what you've just heard? So thinking about Sue's introduction there to the ARMA inquiry into health inequalities and deprivation. I think it's also useful, given that this links so well with Aoife's talk, that if there's anything that you wanted to share here, we will be able to do that. But also, I know Cassie's got the microphone, so if anyone would like to ask a question in this section to the panelists, then please do raise your hand as well. So let's see what's coming through. Thought-provoking, yes. Challenging, shocking. Access. Now, access, I think, is an interesting one, and I might raise that then with the group here. So, Sue and Jane, I wonder if access, if there's anything you want to just reiterate around the challenges for people accessing. You mentioned there, Jane, about travel, the cost of travel, trams and buses. And I think we are often too quick sometimes to say, well, hang on, somebody's DNA'd, they did not attend, or they've turned up late. Actually, somebody in the audience mentioned around homelessness. We know health inclusion groups are also several groups that will also have these similar stigmas attached. So, Jane, perhaps you could have a few comments on access, and Sue as well.
Yeah, sure. I think one of the most important things to think about is trying to start where the person is. So what are their strengths? Going where they go if you can. I know that's not always easy, particularly in the moment with the NHS, but that makes the biggest difference. If you can be in their community, it makes it so much easier for them, and it makes it psychologically easier. If they only have to go somewhere 10 minutes away. And we're coming into the season where we've got, lots of spaces opening up as warm spaces. Where I live, there's a mosque at the end of the road. Every Friday it offers free food to the whole community. If physios went in there, for example, you could talk to people. All those warm spaces, just go in there, get to know people. Once they get to know you, an awful lot of people are socially isolated with MSK conditions. Many of them will have mental health issues as well. And so, they're usually very keen if you get to know them. The one thing I would say, if somebody turns up late, please don't send them away. The number of times I've made a huge effort to get to an appointment and the receptionist said, well, you're too late, I'm sorry. And that just crushes me. It makes me feel I can't go back again. You just feel such a failure. And when you go into these environments, you know that you're a failure. You know your body's not working. So you don't need to be reminded by it. So it comes back to this idea of making every encounter positive.
Thank you. Thank you, Jane. I think that's really salient, isn't it? And we all recognise that. So we'll take a question from the audience now as well. Hi.
Hi, Nicola Vidas, physio and clinical lead for MSK Interface Service in the North East. My question relates to waiting lists and prioritisation on waiting lists. Many orthopaedic waits are still struggling to meet 52 weeks for knee, hip arthroplasty, physiotherapy services over 12 weeks. And currently, waiting lists are typically managed on chronological order of when you get the referral. And that's creating a further inequality of those in the core 20 group suffering poor health, using great health services, turning up at A&E in that period while they're waiting. If we're to really get serious about addressing this inequality, is it fair and is it avoidable? And should we be considering those in the core 20 IMD 1 and 2 to be prioritised and seen earlier on a waiting list, and dare I say it, rationalised care for those not in the core 20? Because the money's not there to really see as many patients as we want to see.
What an excellent question, Nick. I think that really is salient. So just to say on that, certainly I think we need to think differently, ask those types of questions. Some of the recommendations that come out of the inquiry allow us to use the inquiry. Again, there's summaries that we have of this here. You can use this and start asking those questions of your managers, of your teams. But if I then send this across to the panel, would anyone want to take that?
Yeah,
yes.
I'm happy to say a few things. I think, this is a really timely, pertinent question because these discussions are very live at the moment. We know that people with people who live in the more deprived areas wait longer for treatment than people who live in the least deprived areas. And there are lots of possible reasons for this. And there are services that have tried to drill down and work out what the reason is. And they are many and various. But the bottom line is it is not fair for those people to wait longer. So you could say, oh, we must do it just on clinical basis and, then that will be fair. But it just isn't. Treating everyone equally does not give equal outcomes. So things like a lot of those people will have more complexity, they're more likely to be living with obesity, they're more likely to struggle to engage in kind of being prepared for surgery. And if we just say, oh, that we'll leave the more complex ones, because the drive is to get the waiting list down. And for as long as the only thing a hospital is measured on is how short are their waiting lists and how many people have they got off that 52-week wait, the drive will be to do the easy people quick, and that will not deliver health equality. It's not equitable. And some of the initiatives that are brought in to enable people to get treated more quickly are much more difficult. So if you have got to, if you can choose the hospital you go to on the basis it's got a shorter waiting list, well, if you've got money and your family can come with you and stay in a hotel overnight to support you to do that, great. But if you haven't got money to do that, you haven't got a way of getting to a distant hospital, that is not accessible. So there is a real and genuine tension between the drive to bring waiting lists down and the drive for health equality. And that's before you've even talked about those people that aren't even in the system. So there's a huge amount of unmet need there. Now, if we wanted equality, we would go out, we would find those people, we would add them to our waiting list. So our waiting list would actually go up, not down. And it's a very live debate about where do we sit that balance between waiting lists and equality. And there isn't an easy answer. There is a tension there. But if we ignore equality and only measure hospitals on waiting lists, we will end up with inequality. That's inevitable.
Thank you, Sue. And Anthony, did you want to come in as well on that?
Yeah, sorry. That was a really good question. And I think, I know Joe's in the audience who does some research with people experiencing homelessness. But the work that I've been doing recently, going into food banks and into homeless charities, actually there are a huge number of people who require care that don't even have the ability to get onto a waiting list. So whether that's the access to the front door through GPs, language barriers, understanding accessibility, people that are coming from various different populations, actually to get onto a waiting list in the first place requires a certain degree of skill. So there is this invisible population out there that require healthcare. And I'm thinking sort of from an MSK point of view, we're seeing people who have got problems who aren't even on a waiting list. So the problem is a lot bigger than what I would suggest the numbers we have, that is a massive issue, but the problem is bigger than that. And Sue mentioned that as well. So.
Thank you very much, Anthony. Yeah, so thank you. Great question. We will take one more question in this segment. So,
Chris,
oh, yeah.
Sorry, I've got one question from an online attendee asking why is there such a low data point for the health inequalities in women's health? A big change is required in terms of addressing women's health. Is there a plan going ahead to address these concerns?
Okay, yeah, good question. So does anyone on the panel wish to mention about women's health there or have a comment regarding women's health?
I'll have a quick comment. We have initiatives now, don't we? And we have a kind of czar for women's health. But I think it's always been the male as norm. Same as with all research has been based, we know, on the male body as norm, the male mind as norm. And so treatments have not been specifically, created with women in mind, whether it's therapeutic, whether it's drug statements. And that's changing now, but we've got a huge history of that to overcome. And it's changing very slowly. And I think women you know, by and large, although men care, women are still expected to do the caring. They're expected to, you know, men are allowed to care about, but but they don't have to equate that with caring for. Women, if they care about someone, they still have to care for them. That's expected still, unfortunately. So, you know, women are also looking after many other people's health, and their own health suffers there too. So you've got a number of factors coming together, not least that, you know, in addition the fact that, you know, women still get seen in terms of their hormones, their mental health. You know, the number of people who get told that their pain is down to anxiety or depression rather than something else. It still continues. It shouldn't, but it's still there. So I think there are a number of factors to address there.
Thank you. Yeah, I think we will, in interest of time, because we do have another Mentimeter section with another question and answer part of this. But thank you for adding your responses. I think a lot of those are certainly resonating with you emotionally, you know, saying thought-provoking, sad and shocking. But I think, again, in the middle there, these are avoidable and actually also challenging, but we can hopefully help you rise to that challenge. So I'm now going to introduce our next speaker. So Dr. Anthony Gilbert, as I said, a research physiotherapist, to give us a little bit more experience into his work. So, Anthony.
Thank you. So I've been asked, I've got 10 minutes just to describe some of the work that we've been doing in Enfield, working with people who are experiencing deprivation with musculoskeletal problems. And I think I'll just to get started off, I think I'm just going to put it out there. You know, I'm an educated person. I have a PhD. I drive a car. I own an iPhone. You know, I live in relative comfort. And I wouldn't say that I experience deprivation, but some of the people that I've been going out to see sort of in communities, it is really challenging. And reflecting on something that happened to sort of my family this year, my eldest son, who's 12, got a compression fracture in his spine. My knowledge as a clinician, I was able to sort of navigate the system and get him to where he needed to be. So he was able to access care. And when we're talking about access earlier, thinking about how people do access and people who may be homeless or rough sleepers or experiencing food poverty, there are preconditions that you need in order to access care. So next question about waiting lists, there are people there that may not have the preconditions to access, and that's become really obvious to us working in communities. So as I mentioned, I'm a research physio. My role at the moment is I'm evaluating a programme of work. The Royal National Orthopaedic Hospital and the Royal Free London launched a musculoskeletal health hub in Enfield, which is a borough in London. It's one of the more deprived boroughs, but actually if you look at the breakdown within Enfield, on the west side of the borough, there's high levels of affluence, and on the east side, which is where we're based, there is a high level of deprivation. And you know, this hub was set up, it was funded by the ICB, and it was there to sort of support and to try and address the orthopaedic backlog within north central London. And so we've got first contact practitioner pathways, we've got secondary care and tertiary care pathways, and looking at the people that were coming through from the local area, we made the assumption that we would sort of be on point with getting people from areas of deprivation into our service. And when we critically reviewed our data, actually we were seeing that the people that were coming into our service had less deprivation than the borough average. So we weren't really hitting that target population. We then sort of did a huge amount of work with local groups, did a lot of engagement. We went to local mosques, we sort of met people at the Breakfast Club. They run on a Tuesday, so it is a great place where the community come together. We attended climate cafes, we sort of pitched to them and told them what we wanted to do, and that was to support people with musculoskeletal conditions, but particularly targeting people who experience deprivation. And through that work, and it took a lot of effort, and thinking about sort of what John was saying earlier on about equity and diversity, you know, to be equitable, that takes a huge amount of resource to do that. So what that looked like was myself and a few of my colleagues who are really senior clinicians going out to places on NHS-funded time and engaging with people. You know, we weren't necessarily seeing any patients, but that took a lot of investment in order to do that. It's really hard. But through these processes, we met some amazing community leaders that were able to signpost to different places. And one of the sort of really important suggestions was, rather than just talking about musculoskeletal care and trying to get people in with a musculoskeletal problem, was actually trying to get out there and to piggyback on some of the existing networks that are out there, so particularly food poverty. And we made the assumption if people are attending food banks, they're hungry, they are experiencing deprivation to some level, and that'll be a really good place to start. So we sort of infiltrated this large community network within Enfield, went out to different food banks, and again, on that engagement piece and investing effort and time and resource, myself and my colleagues spent a few weeks volunteering in one of the local food banks, handing out food to benefactors. And through that process, we're able to talk to some of these people. It was really obvious. You would see people coming in with, I mean, I don't know where they got them, but these prams that they were using as like walking aids. They'd be piling their food on and then they'd be going. You see people coming in on crutches. And as an orthopaedic physio by background, it looks like they've shaved the bottom of the ferrules, and that just fills me with anxiety. But goodness knows where they got these things from. But obviously there are people there with musculoskeletal problems. And then you start to talk to them. They are unable to prioritise healthcare in their lives because they're focusing on getting food in their bellies, working for heating, all of these other things. They've got other problems. And anecdotally, there is just this acceptance that if you have a problem, it will just get worse and worse and worse, and then you can go to A&E, and then A&E will let you in because that door's open. So it sort of brings about this really interesting and important conversation about how people get in to access healthcare. So we met lots of people that required support, and what we did is we launched an outreach service. So we send clinicians now into community organisations, so into food banks. We've got three food banks that we're at now. We go to a community kitchen where people can get food from their food banks and they can batch cook all of their food, so they don't need to pay for heating or gas and all of that sort of stuff. And when we go to these locations, we're sort of meeting those target population. They're not walking in the front door into healthcare services, but they are out there in the community. So we've established this outreach service, and what we've done through that is we'll go out there and we will talk to them. We can give them some basic advice and guidance, but if they need something else, we're booking them directly into our clinic. So we've got a consultant physiotherapist, Rishi Navsaria, who leads that service. And even then, you could argue that we're making it really easy for people to come in. We've still got a 50% DNA rate. We're booking, we're going to meet people. We're saying, look, here's a bit of paper, go into the service. It's just around the corner, it's just there. But even then, we're still having that high DNA rate. And we've done some work and some research to sort of try and understand why people are not coming. But again, it's that prioritising healthcare in their lives, because they've got so many other things that for me as a middle-class person who drives a car and has a job and is all wonderful, those challenges I don't experience on a day-to-day basis, and it's very different for these people. And I'll admit, that was really invisible to me as I've sort of gone through my life. I've not experienced hunger, I've not experienced poverty. I'm very fortunate, but I'm now starting to see an insight into some of the real challenges over the last 2 years working with this population, the real challenges that they're experiencing. So, as a research physio, I've applied for funding for some, to do some research, and I'm thrilled that we've been awarded some funding from the National Institute for Health Research to do a project, and we're focusing on the challenges people from deprived backgrounds face when trying to access care. And I think research is so important, and to be able to capture these stories is massively important, to be able to sort of mobilise that knowledge into the wider population. But we are out there. We are doing our best to try and support these people. Now, what we can say is we've had about 120 people that have come into the service now. We've managed to collect paired data, and we've got completed data sets for about 30 people. That's given us an indication that if we can get them in to healthcare, we can support them and we can help them to get better. There are some really quite harrowing stories about the state of people coming in, the challenge they have. And this isn't the normal caseload that our clinicians are seeing. So we've had to work really closely with third sector organisations. We've now got sort of a Thrive to Work organisation charity in with us. We've got a massive Turkish population in the area, and we've got a Turkish and Kurdish advocacy group that's sitting in with us, giving sort of health coaching and health navigation support. Within our MSK hub, we're trying to make it as holistic as possible and have all the services available under one roof. But actually what we're finding is we need to be going out into the communities. So when we go to the homeless charity, for instance, there's housing information, there's like social workers, there's alcohol and drug abuse charities. We are a small piece of that puzzle, and we as sort of musculoskeletal practitioners cannot do it alone, and it's about working with this sort of wider group of people. And what we recognise is that, together, collectively, we're all greater than the sum of our individual parts. But that sort of healthcare delivery model looks very different to what I've experienced as someone working in secondary care or tertiary care. The people who can get to tertiary care or in secondary care are able to navigate the system, but it's the people that are rough sleepers, it's the people that are experiencing food poverty. They simply, for whatever reason, are unable to get to those places, and they have healthcare needs, but they're just not quite accessing it. So I think it sort of raises this really important question about how do we get out there and how do we deliver healthcare services for these people who really do need it. Constantly we're having conversations, is this cost effective? Is this value for money? And they're really important questions, because in a sort of zero-sums game world, there is only so much to go around. But if we are actually really being serious about addressing this issue, we are going to have to work really hard to do it. And, we talk about underserved populations, and my question to you will be, how are you serving these people? How are you serving the people that are rough sleepers within your services? And, when we talk about hard to reach as well, are we working hard enough to actually reach those people, to bring them into our healthcare service? And I will leave that there. Thank you very much.
Fantastic. Well, thank you very much, Anthony. And I think, I'm sure you're all, that's really resonated with you as a real example of how a service, a musculoskeletal physiotherapy service, has acted differently to try and reach these populations. And it's a reminder for me, we are physiotherapists. We train with a science foundation. We train to deal with complexity. And I do really think we as a profession are well set to rise to this challenge. So with just the last 10 minutes of the session to go, we want to get your thoughts again, specifically on what action will you take as a result of what you've heard today. And so this is a few responses that those of you earlier on the Menti would have flicked across and asked. But just now, if you can go back onto your Mentimeter and then add some of these suggestions here, and then we can have a discussion. So listening more to the patient, reflecting on our service. Again, the first part of the ARMOR inquiry states that we should understand the drivers of poor health, but then this act now, this sense of not remaining stationary just due to the sheer scale of this, actually understanding that you and your services can have this discussion, leave today thinking, how can we connect and understand our service better? So a few other points coming up. Consider how we prioritize, that's good. Connect with the community groups. Co-production with client group on whether group exercise was wanted and how to reduce the barriers. I think that's always a salient point, isn't it? That we're trying to make sure there's a shared decision process with our patients, and actually we as clinicians don't just lead into a passive type of healthcare. Service promotion in warm spaces, food banks, homeless, and consider our waiting list prioritization. These are excellent ideas. So has anyone got a question at all? Cassie at the top there, thank you.
Hi, sorry, my name is Mary. I'm a physio. I asked a question at the other one, but I'm reintroducing myself. So I suppose my question or comment would be that I'm involved in that term or phrase, place-based working, getting into the heart of communities to find out what makes them tick. And I think some of our challenge is a huge culture change is necessary in our mindsets as professionals. Sometimes we go in with our expertise and our priorities, and actually I feel that we need to leave that at the door when we're working with people from local communities. There is also some proactive risk-taking necessary in the way we approach things. I think certainly in my previous roles, I've been so worried about risk aversion that I've limited how I've approached somebody living with challenging conditions. And an example would be I worked with an older population who really wanted to get active in a deprived area, but all that was available was a chair-based exercise group in a community hall where they sat around in a circle and straightened their knees. So what we did was developed parkour for older people. Now that blew my mind because I was so scared that something was going to happen to these adults who have lived independently for 85 years, and I felt that was all on me. And I think sometimes as well we can become consumed with outcomes, short outcomes, like how can we prove this is working, where actually with populations in general, it's that front-loaded approach that's needed, and we may not see the repercussions until a year later, and that's really hard to fight that fight when you're having to report data. I think we know we're making a difference, but it doesn't always come out in that 6-week period. That is easier to report when you're having to kind of prove what you're doing is right. So that's all I'd like to add, and well done on that work in Enfield. That sounds amazing.
Thank you. That was a really useful comment. And another question, I think, here. We've still got a little bit of time.
We've got some down here.
And
One
then
here.
One here and then one down here.
Yeah, we've got some. Thank you. My name's Richard. I work in the Community Musculoskeletal Trust in the Midlands. It's my thoughts after Sue and Jane's talks, and then I do have a question at the end. So we're tackling a societal illness of which we're saying we have 20% influence. And what can we do? Well, we can do more. We can make every contact count. When you looked at what that means, that a lot of that isn't necessarily rocket science. It's being invested. It's listening with fascination. It's showing empathy. It's gaining trust. And if we achieve all of that, we might just have gained enough purchase to influence something positively. But that takes time. It takes resources. It's personally very taxing as a clinician to invest at that level. And if we're really wanting to deliver this flexible, personalised coaching, we need to value that takes extra resource and cost, because if we don't, we're just passing on this societal burden to a workforce. I mean, you're preaching to the converted here. Everyone in this room wants to do the best they can do, but we can't burden ourselves with all of that responsibility. So my question is there a recognition that this just can't be shoehorned in to a stressed system? This needs costing up and properly resourcing. Thank you.
I think that's an excellent, claps around the room as well. Yeah, I think that's an excellent question, and my personal take on this is that actually these health inequalities, population health, needs to be woven in and through services. But quick to the panel then, Sue, did you want to come on to that?
Yeah, I mean, and I think we are acutely aware of, hats off to anyone who is still working in the NHS, to be honest. We understand that this is a massively challenging environment, and trying to do anything is even harder. One of the things that I'm seeing a lot of is people like yourselves who are desperate to do this stuff, who really get it and are really excited at the possibilities of what could be done, but are not getting that support from higher up. And that's one of the other things that we are trying to do, is to get MSK on the agenda at the ICB level, so that the ICBs are actually making MSK services a priority. They should be, and we've just written a report about why they should be. But we still struggle with a real problem in the NHS, that it is the things that kill you that are prioritised. And length of life is prioritised over quality of life. And I think that answers one of the questions somebody made to Aoife. It's obviously not Aoife's fault. She didn't make these decisions. But the core 20+5 chooses what to focus on, partly because of inequalities around life expectancy, not healthy life expectancy. So I think there is a real onus on the managers of services and the people higher up even than that, and the commissioners, to understand and to get to grips with this. But I still think that each individual healthcare professional has an opportunity at each individual contact with a patient to just go in with an understanding of what that person may be facing, and therefore why what they need is different. So we will continue pushing to get this up the agenda higher up, but also I think it's important that everybody here just understands and bears that in mind in all the conversations they're in about service planning and so on. And the other thing I would say, which is a bit of a comment on the previous comment, is there's also an onus on the NHS to stand up and say, we can't do this while the social determinants of health are driving things in the wrong direction. And I know that the NHS in the Southwest has said there is really poor employment in this area, and it is impacting the health of the population we have to serve. We can't do that. we can't serve them unless we do something about the employment. And the NHS convened the meeting between the voluntary sector, employers and health service to say, what can we do about the quality of work in this area? So I will continue championing for the NHS, not at individual clinician level, but higher up, to be saying, we've got to push for tackling these social determinants, because otherwise we're against an impossible challenge.
Thank you. We've got one last question here from the gentleman at the front.
Yeah, thank you. Just want to build on the last gentleman's really well-made point, and I say this as a commissioner, as a clinical director with the ICB, and as a programme director to an MSK service down in the south of England, that the question I just want to put to our panel is, do we think there is a potential professional existential risk in this health inequality space, in the sense of, do we know what the professional value that physiotherapists bring to this space is? And if I give a bit of an example, that within our programme of work in Sussex, we have a defined budget, which I'm sure most people have, and we're having to create a community integration strategy to address a lot of these issues alongside the core clinical care. And we're having to make a conscious decision about how do we create that. And actually the case is there, as Sue pointed out, that actually the solutions aren't always clinical solutions. The solutions are often social prescribers, peer support programs, making sure clinicians can be in that space but not owning that space. And I'm having to make conscious decisions about what part of my defined budget do I spend on the health inequalities programme, which is super important, as well as delivering the clinical care that we need to deliver. So I think one thing we need to think about as a profession is, how do we understand physiotherapy's unique value in this space? So I'm keen to hear from the panel about physiotherapy's unique value in the health inequalities space.
That's a very good question. We are just about to run out of time, but I think, Anthony, perhaps if you wanted to...
Go on, John.
I think, and thank you for the question, and I think, you know, one of the things that we saw yesterday in the students' conference, and one of the reasons I came away quite inspired, was that it focused very much on the 4 pillars of physiotherapy. And I think we need to remember those 4 pillars are absolutely core to this profession. And in answering your question, I'd rely on those 4 pillars. So I think we have a unique position in terms of our leadership and our knowledge of this area or this speciality. So the clinical speciality that we hold in MSK, but alongside our leadership. And the other thing I think we need to remember, and we saw it in buckets yesterday, is that we know we always have to continue in the use of data and the use of research, but actually what I saw yesterday makes me feel really confident that we are using that data and using that research in a really good way. I think one of the things I said on the Mentimeter is we will, and I think it's been espoused by the panel throughout, we will only reach health equality and equality of opportunity through an equitable approach. We've got to start with equity, but the end goal is still equality of opportunity. And I think the pillars within our profession really allow us to do that. So I'm delighted to hear that we have commissioners in the room, because it's exactly those positions of authority, leadership and influence that we need to be in to be able to drive our clinical expertise through our leadership into that quality improvement. And they are the pillars of this profession.
Thank you very much, John. And this brings the session to a close. If you want to explore more, there are lots of great engagement that you had. We do have a networking session. It's a little bit more intimate. We'll have opportunity to get more time with the panelists and myself. That's at 11:25 in the networking zone. But until then, I think there's time for a break. Thank you very much.